Thank you, Dr. Gasparini. Thank you, Dr. Dubner. Ladies and gentlemen, good morning. So you've heard about the merits of programming in primary prevention patients. The merits are that you reduce morbidity and you reduce mortality. So these are significant effects. The flip side is if you don't do this, then perhaps you are creating risk for the patient, risk of increasing morbidity and risk of increasing mortality. So you've heard about this, and I know you're going to be very attentive to programming your own patients in device clinic. And you'll probably tell your friends about it, and they'll tell their friends. So the question I'm asking here in this analysis is how much penetration is there of this kind of information from congresses, presentations at congresses, to publications in high-impact journals. How much penetration is there in the wide world, in the community? So, hence the title, how well do results from large randomized clinical trials diffuse into clinical practice, so community-based practice? And here we looked at the impact of two trials, Intrinsic and Made It Writ, in large cohorts, mega cohorts of ICD patients using the Altitude database. So as a background, generally in heart failure patients, adherence to guideline-directed therapy is very variable. And this is well recognized with medical therapy. On the right, I have beta blocker use in heart failure, trends amongst UK general practice, and you see this is less than 40%. Whether it's a recommended beta blocker or an alternative beta blocker, it runs very low. And this is relatively contemporary, given the data from beta blocker trials. Women slightly underrepresented here. Similar evidence practice gaps exist and persist in US practice. And these are the bases for the Improve HF and Get with the Guidelines committees, which are trying to improve the adherence to guideline medical therapy in heart failure patients. But apart from medical therapy, of course, ICDs are a critical component. They improve survival when used correctly. And as you've heard, correct programming is crucial to gaining the benefits of ICD therapy. If you don't adhere to correct programming, you introduce risk rather than eliminate or reduce risk. So there's a significant fork in the road here. And practice is generally guided by trial results. Trial results from congresses presented there and also high-impact journals, and then recommendations from professional societies. So the question that we asked here was that are seeds optimally programmed in US community practice? And we examined the response to the Intrinsic and the Made It Writ trials. So we used a remote monitoring database, and this is using the Altitude Clinical Science Program administered by Boston Scientific, and using devices with automatic remote monitoring. So these are devices which automatically transmit data via a transceiver, which is processed in a service center and made available for website review. So this is an automatic transmission system. It doesn't require patient participation. So this is automatic and generally very reliable. And the analysis that is presented for website review by the physician, by the clinic, gives us all kinds of information, arrhythmia, device status, but also settings and programmed conditions. So this gives us an ability to analyze community-wide practice settings. So this system generates continuously updated databases. And what we did was to analyze at this point here and look at de-identified data from the Latitude remote monitoring system and analyze this for shifts in practice in device settings. So first of all, beginning with RV pacing and heart failure, and this was very, very important about 10, 15 years ago following the David trial. And as you're very well aware, unnecessary right ventricular pacing in patients with heart failure increased mortality and heart failure hospitalizations. And this was in the DDD platform. So it wasn't the DDD pacing, it was unnecessary RV pacing. And the Intrinsic trial was designed to use a algorithm, AV search hysteresis, which seeks to prevent unnecessary RV pacing, so AV search hysteresis. And the trial results showed non-inferiority of DDD versus VVI. In fact, trend towards superiority with DDD. So once you eliminate unnecessary RV pacing, actually the patient condition improves. And this required the use of this built-in feature, the AV search hysteresis. So we examined what was happening in the community following publication of the intrinsic trial. And the weekly reports on latitude contain right ventricular pacing percentage here. Here it's 92%. So we evaluated a total of 73,949 devices, 2/3 of which were dual chamber devices. CRT devices were excluded for this particular analysis. And we analyzed data transmitted during the first week of the year for each year between 2008 and 2012. So we evaluated a total of 161,000 plus transmissions. So these are the data. This is a analysis RV pacing by year, and Intrinsic was published in 2008. And you see that these results are relatively positive. The incidence of RV pacing less than 1%, light blue here, progressively increases. And the incidence of, or the prevalence, I should say, of RV pacing more than 40% progressively decreases, this component here, over those 5 years. So these are positive results. When we analyzed the dual chamber units, and there were 2/3 of the patients had dual chamber units, you see that the implantation rate of dual chamber units actually increased from year to year, slightly, but significantly. And of those units, those programmed to dual chamber also increased slightly. So these are positive results. Not by much, but there's certainly a trend here. But if we look at the AV delays that were programmed here, the percentage dynamic AV delay progressively increases here. So you see this, it goes from 65% to 81%. So a significant change in the community. And these are the program settings for dynamic AV delay and for fixed AV delay. The incidence of fixed AV delay, which may promote unnecessary RV pacing, actually decreased. So this is positive. But the interesting thing is that AV search hysteresis did not change. So actually the feature that was examined in the intrinsic trial was not employed. I think the principles of the trial were appreciated, and that's demonstrated here with the use of dynamic AV delay, but not the feature that was actually examined for this study. And overall, not a significant penetrance into the community. So in summary, for RV pacing, percentage RV pacing exhibited a downward trend during 5 years, despite increased use of DDD implants and programmed lower rates. The proportion of percentage RV pacing more than 40%, which is really part of the guidelines for considering upgrade to CRT, decreased significantly by 27%, although a significant residual population remained. And this is really enforced by increased use of dynamic AV delay, but not AV search hysteresis. So let's go to MADIT RIT. And I know this has been described to you earlier, so I won't go over this. Arm A, Arm B high rate, Arm C duration delay. And you've seen these results. So we examined the response in a similar fashion to MADIT RIT here between 2008 and 2014. Adoption of MADIT RIT settings. We examined according to 2 levels of analysis here. One is exact trial programming, Arm B and Arm C, and then programming according to trial principles, which we call quasi-MADIT RIT principles. First therapy, more than 200 beats per minute, or long duration, more than 60 seconds at any rate less than 200, or more than 12 seconds at any rate more than 200. So trial principles. We looked at 145,000 plus patients here in US community practice. And this is a typical group of patients. ICDs here 57%, CRTDs well represented with 43%. Age 67 years, females 28%. Of these, 77% were implanted before trial publication. And we'll look at these results according to patients implanted before and after trial publication. But these are the results. These are new implants, 33,812. And you see, prior to publication, at this point here, Naturally, Arm B or Arm C programming was less than 1%. But then it increased following trial publication, but only to 10% in the community, 10.5 and then 11.1%. This is amongst fresh implants. So this was very surprising. It's actually very disappointing that following trial publication, there was very little penetration into the community. Significant, evident, but in terms of degree, very minor. And that applied to both Arm B and Arm C. Although you'll see that although Arm B and Arm C were equivalent, they were equivalent in the trial, Arm B was favored in practice. Arm B was favored in practice. What about made-it-writ-like settings, quasi-settings, as I described earlier? Well, a higher level here, and you see quasi-Arm B, Arm C, prior to publication was about 10%, and it was even over the years prior to publication, suggesting there's an awareness in the community. People were actually programming this way in any case prior to the trial results. And following publication, this also increased. It increased to 23, 24%. But again, very minor penetration into the community. Again, somewhat disappointing. What about reprogramming? Patients who already have devices, who have come into the clinic, and now the made-it-writ results are available. What happened to those patients? So reprogramming, 85,000 patients plus were implanted before publication. Of those, 59% had a device reprogramming session, in-person evaluation, at least once during the course of this analysis. However, only 2% were programmed to strict made-it-writ settings. Again, Arm B favored slightly over Arm C, 1.1 versus 0.8%. But these are trivial numbers. They're very trivial. So this means that patients who are coming into the clinic actually don't benefit from the information that's been presented at congresses and published in high-impact journals. Similarly, for made-it-writ-like settings, only 12% were reprogrammed to these settings. So we're talking trivial levels of penetration here. And this looks at duration here and rate. And if you look across the board for patients implanted before or after made-it-writ publication, you see there's a concentration here for less than 200 beats per minute and less than 12 seconds. This is where most patients are programmed and left, irrespective of the trial settings. But I think the data regarding reprogramming are telling. Implants after publication were more likely to be programmed to made-it-writ-like settings, but implants before publication were less likely. I'm sorry. Patients implanted following the publication date were more likely to be programmed compared to existing implants. And this is all set to the right here for strict settings or quasi-settings here. So the limitations of this analysis are that it's a remote monitoring database. So ICD indications and other demographics are not available in the database. But according to NCDR statistics, and we have a community-wide representation here, 70% of these implants were for primary prevention cases. But extended duration and extended delay may also benefit patients with secondary prevention. But made-it-writ applies specifically to primary prevention. There is a possible selection bias. We could only analyze patients, although it's a huge number and it's nationwide, we could only examine patients committed to remote monitoring. But subsequent data from the Altitude database show actually these patients are the most likely to have best clinical practice in hospitals and also be the most adherent patients. So in effect, this is the best possible subset of patients, those committed to remote monitoring. And still, this is the level of penetration. So in summary, trial publication does elicit an immediate effect, but this is minor in degree, and it does not amplify with time. There's no progressive increase. We have more follow-up data following intrinsic, and there was no increase with time. The level of penetration into US practice has been low, whether assessed by strict trial-specified parameters or by its principles. And in made-it-writ, when adopted, high rate threshold for VT-VF therapy was preferred versus prolonged duration for detection. And adoption was more likely in new implants versus reprogramming of pre-existing implants. So in conclusion, I would suggest that seed programming, which is important, as we know, is generally suboptimal in the implanting community, unnecessarily risking increased patient morbidity and mortality. There's a significant inertia that exists and persists in translation of trials into nationwide clinical practice. But remote monitoring may be used to track and possibly resolve evidence practice gaps in seed management. Thank you.
Thank you, Dr. Varma, for this very interesting data that clearly pointed out that you can publish trial, but then the real application is not so easy. And I would like to return back to one of the major points we also discussed in the expert consensus published recently. That is, okay, we have two or three major companies that decided to perform trial just to say this way is better than the previous one. And this is a bit strange, because by sure I know that Medtronic now is trying to put the 30 out of 40 programming, that is very easy, into the box. And if the company do not move in this direction, the penetration is impossible. I mean, the company performed the study, the results of the study were beautiful. As a result, the company should modify the into-the-box programming, and later on the physician may choose for different for this patient. Otherwise, there is no penetration. But if I understood correctly, there is some difficulties with FDA approval for this possibility.
Yes, I think the device companies have discussed this to change the default settings out of the box, but there is an FDA barrier to be negotiated there. And then, of course, the physician has to adjudicate on whether that particular patient requires that programming. And it may be a secondary prevention patient. But I think it would be better than the condition that exists just now.
Please.
Congratulations for this extremely useful example of how we should deal with these big data analysis. I mean, this brings us forward, and this defines a task for us. It's extremely sad, I mean, how we see this penetration, this low level of penetration. So, I mean, this is a task for all of us.
Thank you.
I actually would like to provide a different perspective, because what I see from your data, that immediately after the trial publication, within 2 years, there's a 3-fold increase in Mediter-IT-like programming in the ICD community. And this is both primary and secondary prevention patients, so it may be even higher. And this is before we have a consensus document on ICD programming. This is before there's a widespread dissemination of this new knowledge. So I think the results are, somewhat maybe disappointing or sad, but could be worse. And I think this will definitely improve after we have the consensus document. So maybe looking at this data again, or looking at the remote monitoring data again, may provide further insights and hopefully more positive results.
Yeah, absolutely. And that's in process just now. So we're examining the response to the consensus document, the reprogramming guidelines, and see if there's a further blip up. What would you expect?
I think we all know that implementation of new therapies or new findings from clinical studies take about 5, sometimes 10 years. So I think I'm not surprised to see this data, and I'm hoping further increase and utilization of this programming. And then maybe these remote monitoring databases could also provide more information on the safety and efficacy of such programming. So I think linking this remote monitoring database to clinical outcome data would be especially relevant.
Yeah, I think so. I think in this day and age, 5 and 10 years for implementation is rather too long, particularly when we have this kind of transmission technology. So I would like to see remote monitoring harnessed to provide a feedback loop. Just as the heart failure community has been doing this for 8-9 years for drug therapy, it's much harder for drug therapy. It's very easy for us. We can just track these patients on remote monitoring. So remote monitoring has also become standard of care in the companion document last year. But going back to your point about amplifying over time, we don't have that follow-up period for made-it-rid. We have it for intrinsic, and that's why I put those data in. It did not amplify with time. It actually decreased with time. There was a blip after publication for about 2 years, and then it came down again, which is very disappointing, which suggests that these data have to be repeated and endorsed. But I think remote monitoring is a tool that could be used to improve implementation.
Yeah, so one suggestion, I don't know if you had a chance to maybe look at patients who had VTs. I know you don't have information on primary and secondary prevention, but maybe exclude patients who had a sustained VT and try to look at that clean patient population of primary prevention and look at the programming again. So
primary prevention was 70% in this community. Just looking at NCDR statistics. So I agree with you, the data is slightly diluted. But nevertheless, a penetration of 8%, if you increase that by 30%, you still get to about 12%. So it's not significant.
Thank you.
I enjoy very much listening to your presentation, Dr. Varma, but this is not news to us. In 1986, the consensus paper on enalapril was published, and in 1993, only 60% of US CSUs were using ACE inhibitors. So the penetration, I agree with Valentina, may take longer than 2 to 3 years until it becomes a spread out practice. What I'm not 100% sure is that insisting in the way of collecting data through altitude will give us all the answers. So I was wondering whether you have thought in trying to understand why this is happening. Because the fact that is worse in the pre-program reminds me the idea that if it's not broken, don't fix it, right? It's an analogy with, for example, the NOACs, right? If you have a patient in warfarin, that it doesn't bother to go and check the INR consistently between 2 and 3. Are you going to switch this guy to an AGA, or you leave it in warfarin because if it's not broken, don't fix it? So what about surveying your community? I know it's large, I know it's heavy work, but surveying, trying to understand why they may be reluctant to update their devices to the new ways of programming.
Oh, I agree. I think this is fertile territory for further exploration. The heart failure community has appreciated this problem for a long time, have taken measures to address it. I don't think this is so well appreciated in the implanting community. We put in an ICD and we believe it works. Absolutely it works. But sometimes it introduces risk if you don't program it correctly, and recent trials have shown that. In comparison, if you don't add ACE inhibitors or beta blockers, you're not helping the patient, but you're not introducing a risk. Here, if you don't program the device correctly, you introduce a risk. So there's a big difference. It's either positive or it's negative. But I think I agree with you. We need to survey the reasons for it, but having devices coupled to remote monitoring gives us instant access to program settings. So we can always ask that question. So that is the next level of exploration.
Although you already introduced the definition of quasi-made-it-rid programming, it was still very strict. I think if you would, I would hypothesize that if you would be able to get your 3D graph of a few years ago, and you would compare it with the 3D graph of now, you would see the cutoffs moving upwards in both rate and time, but I think the 60 seconds and the 12 seconds probably are scaring clinicians, and they end up programming it maybe at 30 seconds and 5 seconds. So maybe it's better to see how much patients are moving away from made-it-rid arm A in the direction of B and C, and not be too negative, I think, at this moment.
So the question is, how often are devices, if I may rephrase that, how often are devices programmed at all from nominal settings at implant? And the incidence is very low. And you're absolutely right, we'll go and do that analysis. And I think this goes back to Dr. Gasparini's point that we have to change the nominal settings because the incidence of reprogramming is very low. Thank you.
Okay, thanks a lot. And the chairman want to thanks everyone because 100% of attendance, you remain until the last minute, and the discussion was great. Thanks a lot.
Wollte ich gerade sagen, ich kann mich schon gar nicht mehr daran erinnern. Hätte ich mich entscheiden können, bin ich hergefahren wäre.